Assalamu alaikum. Hello and welcome to another episode of Care Across Cultures with me, your host, Mirban Hussain. I have an amazing, wonderful guest for you today, who I will introduce shortly. We talk on this program, as you all know, we talk about health, we talk about cancer, we talk about life-limiting illnesses, and I've had lots and lots of different guests on the program, ranging from doctors, consultants, psychiatrists, nurses, survivors of cancer. I've had chairs of hospital trusts. I've had CEOs of hospices and everybody in between. Today's guest is I'm actually feeling a bit emotional today because today's guest is someone who is from Rotherham. He's a local GP, and we were talking just before the programme started about all his family who I know. Not just his mum and dad, but his grandparents as well, and we sort of all lived in the same area for years and years and years, and then we just moved on. So I'd like you to welcome Dr. Tariq Sabir, who is a GP. Assalamu alaikum. How are you?
Welcome salam. Thank you, Mirban, for the very warm welcome. Thank you for inviting me. It's a pleasure to come onto your show today.
Thank you so much. Thank you so much. We have lots of questions. That's what this show is about. Okay. Well, I'd like to start with your journey into medicine. So, what made you want to become a GP?
So I think whilst I was growing up during school, I had this fascination for the sort of human body, seeing how the human body works. That combined with an interest to try and help people, trying to alleviate sort of suffering that some people may go through sometimes. And like most parents, Asian parents, my parents were quite keen for me to be a doctor as well. So them things put together, sort of I had quite a keen interest in medicine. At the time it was seen as being quite a good vocational career to go into. And then I applied, and the rest is history really.
The rest is history. But it's a long process, isn't it? Becoming a GP, well, becoming a doctor.
It is a long process. So after you go through school, college, you do 5 years of medical school. Then you've got to do 2 years of junior doctor training, which is then followed by another 3 years of GP training.
So 5 to 7, 3, 10 years?
10, yeah, so after you finish college, it takes 10 years to become a GP.
Wow, I did not realise. Okay. So those days must have been hard, when you're actually studying, because... tell me a little bit about your university life.
So, I mean, nothing in life is easy, is it really? So I really enjoyed university. I went to the University of Manchester, made some good friends over there. And when you enjoy something, you want to work hard for it. So I really enjoyed my time there. I really enjoyed medicine. I enjoyed learning at the time. So yeah, it was good.
Yeah, okay. So where did you do your sort of after training, after your degree? Because I have lots of friends who are doctors, and they say that they always try not to do it in their own hometown. Is that something that you did?
No, so I probably would have preferred to come back and do it in my hometown. So initially my junior doctor training was based in sort of the East Midlands and northern Lincolnshire.
Okay.
And then for my GP training I came back to Rotherham, and I did my 3 years of the GP training in Rotherham.
Okay, that's great, thank you. So, you wear a lot of hats. Okay. We're going to talk about some of those. But the hats that you wear seem to point to one thing: health inequalities. is what drives that passion for health inequalities?
I think for me personally, so for our listeners out there, health inequalities are health outcomes that can be based on your background, where you live, your culture, how much money you earn. So these things negatively impact your health outcome. And I remember when I first started working as a GP, I was working in quite a deprived area, and it was one of the top 10% of the most deprived areas in England. So that really sort of motivated me to try and help solve some issues with health inequalities within my area. I actually, when I first sort of qualified as a GP, I did a fellowship in health inequalities as soon as I qualified, just to try and help people in the circumstances, to try and help sort of remove some barriers, to try and eliminate health inequalities in certain settings.
Okay. So what's a fellowship? I don't know what a fellowship is. Help me understand.
So it's just a year of an extra training, specifically on health inequalities. And in that year we sort of focused on working with sort of ethnic minorities, working with people from deprived populations, working with the homeless, working with asylum seekers. So it sort of tailors you and gears you up to try and help people in these circumstances, trying to help them navigate the system in order to sort of better their health outcomes.
So to help me understand, when we talk about health inequalities, I'm just trying to sort of understand what that actually means, because it's a terminology, health inequalities, and some people may not understand. So if you were trying to explain health inequalities as a GP to one of your patients, say it's a lady from Yemen, yeah? How would you explain health inequalities to someone like that?
So what I would say is it's sort of your health outcome, which can be negatively impacted by where you live, the background that you're from, your career, the amount of money that you earn, your understanding of English.
Okay.
So these things negatively impact your health outcome. And the reason why that is because the health system isn't built to be cruel. However, sometimes it can favour people that are more educated, more affluent. And the reason why that is because the way the system is built and made, for example, I think we're going to probably discuss this a little bit later on, cancer screening. So a lot of the way cancer screening is advertised, it's used sort of complex English, it's uses the internet, uses the radio, and a lot of the time people from a deprived area may not have access to the internet, may not have access to the radio. These people might not have a good understanding of English where they're able to read about sort of health screening and cancer screening in order to be able to access those things.
So information is a key thing, isn't it? So I like the word you used earlier, that the health system is not set up to be cruel.
Yep.
Because I come across this quite a lot, and I have done over the past 30 odd years that I've worked in health and social care. Some people, you know, I suspect more one time feel that, oh, this is bad, this is discriminatory, it's all against me, but it's not, is it? You know, that's what you're saying. It's just that the way that it's set up, because it has to be standardised to a certain extent, doesn't it? Yeah. We can't, I would love to be able to provide personalised care to everyone, but I think it's just not practical, is it? But it's, what does someone do then if they have these, a language issue, for example? Let's take communication. If someone came to you, you know, one of your patients, and they didn't speak English, and you didn't speak whatever language they spoke, what can they do about that?
So we do find a lot of time people avoid going to see their doctor because they are not able to speak English, and sometimes this acts as a barrier for them to seek help within the healthcare system.
Yeah.
Now, within the NHS, within GP surgeries, within hospital, we have access to interpreters, okay? This is over the telephone, this can also be face-to-face. So if ever somebody came to see me but they didn't have a grasp of English, we have interpreters that we can contact through the telephone and sort of have a three-way conversation with somebody. And I do find that normally helps, and sort of because these interpreters have training and they're qualified medically to be able to help translate for these people, and it just helps somebody to be able to express what they're feeling.
Okay. Fantastic. So they can access that, they don't have to sort of pre-book it if they just turn up for the appointment and you find that's the first time you've seen them.
Yep.
The first time they've seen you. And you can access that straight away pretty much, can you?
Yeah, so literally we have a number, we ring the number, it gives us options of what interpreter we want, what language we need, we dial that in, and within a few minutes the interpreter is available.
So, listeners, you've heard it directly from the mouth of Dr. Tariq Sabir. Even if you don't speak English, go to your appointment and they'll arrange an interpreter for you. So please, 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 and I always say this, do not leave your illness. Your health is very important. Make sure just go for that appointment. Make the appointment. Go for it. It doesn't matter if you've got nobody you can take with you, because the GP's job, part of the whole service, is about making sure that they can understand you and then they can treat you better.
Yeah. And one important thing that I want to say is a lot of people tend to bring family members to appointments, and that's absolutely fine if that's who you want to interpret for you. But there's some sort of issues which can be quite sensitive for people to discuss whilst their family members are there. And I think in that scenario, it's important for them to be aware that they can come to the surgery, can come to an appointment. They don't need to pre-book an interpreter, but when they come, the clinician can sort of dial in an interpreter for them to be able to discuss whatever they may need to.
And that's not just to see the doctor, that's to see anybody within that.
Anybody, yeah, whether it's the healthcare assistant, whether it's the nurse, we all have access to what we call language line, where we can get some interpreters from many different languages.
Okay, that's great, thank you so much. I'll talk a little bit about what are the biggest gaps that you've noticed in cancer care for some of these minoritized groups. And I'm not talking just about the black and Asian minority, because we're talking about health inequalities in general. What are some of the things that you've noticed, gaps?
So overall in this country, I think our cancer care is very good. Where I think we're sort of falling back a little bit, especially in terms of health inequalities, is the uptake of cancer screening. Okay, now I think with cancer screening, it's shown that people from sort of affluent areas that are educated tend to uptake cancer screening a lot more than somebody that's from a deprived area that doesn't have the same level of education. And I think a lot of that is probably due to awareness. Not many people know what cancer screening is and why they're having the cancer screening in the first place, or how they even access cancer screening. So there's a few sort of certain types of cancer where there are national cancer screening programs. So this is for bowel cancer, this is for cervical cancer, and also breast cancer. So once you reach a certain age, you are invited, or you are sent a testing kit to your house to test for these certain types of cancer. And a lot of people aren't aware this is the reason that they're being sent. A lot of people think this might just be junk. A lot of people aren't able to actually read the letter to be able to tell them actually this is for a cancer test. So I think these are sort of the main reasons why in certain communities especially that we are finding that there is quite a low uptake of cancer screening.
Okay. And that's across many sort of health inequality groups, isn't it? It's not just specific groups, but lots of different.
Yeah, so that is through sort of many different types, in terms of ethnic minorities, in terms of sort of areas of deprivation. So yeah, across sort of the board, really.
Also, learning disability,
Of course.
because they have sort of some unique challenges in terms of understanding. Yeah. And also there are some specific groups like the LGBTQ community who face specific barriers, across the board. Okay. What do you think, and also based on your experience, would stop people from going to see a GP when they have some symptoms?
I think there's many reasons. One of them is that everybody's very busy nowadays, trying to find time to book in for an appointment. And I understand nowadays it's quite a challenge for people to book in an appointment in the first place.
Yes.
When you try and ring first time in the morning, you're sort of 50th in the queue.
Yes.
People don't have time to wait an hour to be able to speak to somebody on the other end of the phone, to be able to book an appointment. And I think we as a health service need to try and address that, and we are in the process of addressing that. We now have online, every GP surgery now has an online service where you can send a message and you can have an appointment booked that way. So that's one of the reasons. The second reason is fear. A lot of people fear that if they go to the doctor, they may need to have some further tests. They may not want to have these tests doing.
Yes.
And certain sort of symptoms which a lot of people associate with cancer, people are just worried to be able to go to the doctor and be told, actually, you might have cancer. So I think
it's a fear, isn't it, of what I think, what people don't seem to understand is that just because you've been invited for a test does not mean that you have cancer. And I'll give you an example of lung cancer screening. Of 100 people who are invited for a lung cancer screening, I think the figure is around 94% are told, go away, there's nothing to worry about. Yeah. And when you sort of try and put it in that way, it sort of puts, and that's the fear that you mentioned earlier, isn't it? Just because I've got this test, I've got cancer. And it's not, it's just a routine test because you're in a certain group, age-wise or something else. And it's really good to just go for it.
I think you're absolutely right. The majority of cancer screening tests, people will come back with a normal or negative result. Only a very small amount of people will possibly have cancer following a screening test. And now the reason why that is important is because cancer caught early has more chance of treatment and also cure.
Yes. Yeah, that's very true. And I can talk about lung cancer because I'm a lung cancer survivor. And I went for this healthy lung check. And in my case, they found it. It was early stages. They were able to operate, take it out, and 3 years later, I'm cancer-free. Okay, and that to me is, I'm a bit of an ambassador for lung cancer screening, and I'm saying that, okay, if that's worked for me, I had no symptoms of any description. Yeah, so if that's worked for me, it can work for you as well, can't it? And it's those 4 stages of cancer, 1 to 4. And I know about lung cancer because if you're caught in the first 2 stages, 100% survival rate. So even though you've been invited for a lung cancer screen, yeah, and even if you're one of those people who is diagnosed, the potentials are that you can be treated and cured. Yeah, and that's a really important message to give people.
Definitely. And I think you are the perfect example and a success story of cancer screening. This is why cancer screening was formed in the first place, to try and catch a cancer when people don't have symptoms and trying to catch it early, to try and increase any sort of survival or treatment chances.
Yeah, thank you. One of the things I just wanted to pick up is that earlier you said about telephone calls, making an appointment for the GP. To be fair to GP surgeries as well, is that Yes, it is a difficult thing. When you phone up, you're usually about the 50th there, and that's at 8 o'clock. Okay.
Yep.
So how are you the 80th when you've rang bang on 8 o'clock? We don't know. Okay. But some surgeries now offer you a callback service, don't they? And you don't lose your place. Because I've done that, where I've accepted the callback service, and they've then rang me. So this was at 8 o'clock I phoned. I got the callback service offered at 10 past 8. Yeah. I accepted it, and they rang me at 10 to 9, and I still got an appointment. So just because you accept the service doesn't mean that you're going to lose your place. And a lot of it's got to do with GPs are very busy. You know, I know that. Yeah, they are very busy. There's lots and lots of work that they've got to do. It's not just seeing patients, is it? There's lots of other. Tell me a little bit about what else you guys do.
So apart from seeing patients, we deal with prescription requests. We have to look at all the tests and the blood tests that have been ordered for different patients, and when the results come in, we have to go through each result individually, and then action those results. We have to go on home visits, so people that aren't able to come to the surgery, we in the afternoon usually go out and see these people at home, and that can sort of take up a considerable amount of our time. We have to do referrals for patients that we have seen during our clinics. We have to read letters from the hospital for patients that have been seen in the hospital to see if there's been any change in their treatment plan, and action those changes as well. So the work isn't just seeing patients, okay? There's a lot more that happens in general practice than just seeing patients.
And I think that's the key thing, isn't it? Because we don't know. The general population doesn't know. All they know is that the GP is there, that's who I go to see because, you know, I've got a problem and I can't get an appointment. Well, what are they doing? Because I'm sure you've heard this.
Yep.
I hear it all the time.
Yeah.
And it's just about helping people understand that, you know, no. Just because, you know, you can see your GP from 8:30 till 11 and then from 4 till 5 or 6, whatever it is, doesn't mean that they're sat at home doing nothing. There's a lot more that they have to do. Okay, that's great, thank you. We've talked about language line, okay, but there's much more challenges that, and we've talked about fear as well, haven't we? How can GPs better support people from different backgrounds? And when I say backgrounds, I'm not just talking about culturally or ethnically. I'm talking about all of the ones that you mentioned, socioeconomic deprivation, all of that kind of stuff. Is there something that's happening within your surgery that you can share?
Yeah. So, for example, I think one of the examples that you gave earlier on was somebody with learning difficulties. So I had somebody a couple of weeks ago who was trying to access some benefits, and they were needing to fill in a form, and they were struggling to sort of fill in that form due to their sort of learning difficulties. Now in practices we have somebody called a social prescriber now, right, and they've got lots of different roles, but one of the things that they can do is they can direct patients to services that might be able to help them.
Yes.
So for this specific person, they were directed to the Citizens Advice Bureau, who helped them complete this form, and as a result of that, they were able to access benefits.
Benefits which they needed.
Yeah. So
there you go. So you know, that's really important. Social prescribing is one of those really great things, isn't it? It really is, and a lot of people don't understand how much support that they can actually give. Am I right in understanding that, if not all, most surgeries have some social prescribers attached to them?
Yes, so nowadays GP surgeries are working together as clusters called PCN, so primary care networks, and usually within that primary care network, and especially in the South Yorkshire area, there is usually at least 1 or 2 social prescribers that are working. So most GP surgeries will have access to a social prescriber.
Fantastic. We are coming to the end of this section, so there's a short commercial break coming up. If you are just tuning in, you are listening to Care Across Cultures with me, your host, Mehban Hussain. We're coming to a break, and we'll be back after this break. Hello, welcome back to Care Across Cultures with me, your host, Mehban Hussain. I've been talking to the wonderful Dr. Tariq Sabir, local GP in Rotherham. Just to remind you that the views and opinions expressed on the programme belong to me and my guests and are not necessarily those of Link FM or of the organisations that we represent. I always ask, how would you prefer me to call you? Dr. Sabir, Tariq, how? You tell me.
You can just call me Tariq.
Tariq,
yep.
Okay, that's great, thank you. Should have done that first, but never mind. I've just been I was so sort of enthused about having you on my show because of all this family connection, and I forgot. Okay. So one of the key things that we find within any sort of relationship, is building trust. So we're talking about, not just any illness, but we're talking about something like cancer or life-limiting illness or terminal diagnosis. Why would I open up to you if I don't trust you? And how can as a GP, how do you build trust with patients who present in that way?
So I think you're right, Mehban. One of the other big barriers in people sort of accessing healthcare is mistrust of the system, mistrust of the healthcare. Now, sometimes it can be really difficult to gain somebody's trust. I always find that treating people with respect, giving them a chance to speak, and most importantly, asking them what worries them the most, and addressing that concern. I do find addressing people's concern does sort of help them to try and trust you more, and also to try and trust the system more.
Okay, well, that's a good one. That's good. So I want to talk now about specifically around cancer. And what we mentioned earlier about cancer, when people hear the word cancer, we automatically think death. Yeah. Even though cancer care, cancer treatment has improved so much over the past 30 years. There was a time 30 years ago that we wouldn't even use the word cancer, we'd say the C word. And now it's much more acceptable. Now, death and dying. Because the first thing we think of is cancer, death. Now, death and dying is viewed very differently across different cultures. For faith communities, death may be a transition. We're moving on to somewhere else. It might be a rebirth, as in a reincarnation in terms of the Hindu faith. For Muslims, it's okay, this is our sort of allotted span. We are now moving on to the next transition. And Rotherham has 42% of no faith. And there's the humanist view that this is it, this is our life, that's it. When we're done, we're done. Okay. So, if we're looking at you supporting someone in terms of their beliefs around death and dying, what experience have you had in terms of patients that have come to you who've talked about those things with you, their fears and their worries, and what have you done with them in terms of helping them understand?
Yeah. So I think it's important, first of all, to ask people what is important to them. Okay, what is important to them when they are toward the terminal phase of their life or toward the terminal phase of their illness. what do they want to happen when they die. Are they wanting to be buried? Are they wanting to be cremated? What do they want? Where do they want to die? So I think it's important to have these conversations very early on with people, so you're able to plan to see what happens when they do become more unwell.
Yeah. So, and the reason I jumbled that up on the question on purpose, because I'm really wanting to talk about something that we in the healthcare call advanced care planning. And this is for terminal diagnosis or a cancer diagnosis. So what you've talked about is that it's an advanced care planning, and I would really like for you to sort of elucidate, if you will, for our audience and our listeners, what does advanced care planning really mean, yeah? And what are the practical implications of advanced care planning?
So in essence, advanced care planning is you having a conversation with your healthcare provider about what you would like to happen in certain circumstances, if you become more unwell, if you pass away, if you get an infection. Okay, for example, one of the common questions that we ask people is, say you get a chest infection and we can't manage you with antibiotics at home. Are you wanting to be left at home just to be kept comfortable? Are you wanting admission to a hospice? Or would you rather we admit you to hospital and for them to try and give you treatment at the hospital? Now, when somebody is toward the end of life, sometimes they just may want to be kept comfortable. So it's important to discuss these topics. Another common conversation that we have with people that are given a terminal diagnosis is about the do not resuscitate form, which in essence means if as your illness progresses and your heart stops, what do you want to happen? Do you want somebody to resuscitate you, despite there being very little chance of them being able to resuscitate you? Or do you want to sign a do not resuscitate form, which basically means that if your heart does stop, then we will just keep you comfortable.
Okay. So resuscitate basically means restart your heart.
Yep.
Okay. And it's very key in certain circumstances when people are so ill, they're so frail.
Yep.
They're already at, they've got a terminal diagnosis, so they might be at end of life, as we say.
Yep.
Okay. And the chances of a doctor restarting their heart are very slim, and if they do, it might cause them more damage. And is that about quality of life then, isn't it?
100%. And I think sometimes we're under the false pretense, because a lot of the time if we see on sort of films that we may watch that once somebody is resuscitated, it's a very pain-free process,
Yeah.
and within 5 minutes they are resuscitated and then they just continue as normal. And it's not quite like that, unfortunately, especially in somebody who's already got a terminal illness, had other medical problem. The chances of resuscitating somebody is very, very little. And even if you do resuscitate them, they are very unlikely to have the same quality of life than what they did before. And a lot of the time, the medical advice given to somebody is that somebody with sort of many medical comorbidities and also a terminal illness is that actually it's probably better for you and better for the quality of your life if you're not resuscitated, if your heart does stop.
And natural process.
Natural process, yeah.
Natural processes. Okay, thank you for that. I want to take the conversation now in a different way. I'm going to want to look at and talk a little bit about your role as a medical examiner. I don't even know what a medical examiner is, and I'm sure some of my listeners, or many of them, also don't know what a medical examiner is. And the reason I want to talk to you about this is because recently we've heard, as Muslims, we've heard the term medical examiner quite a lot. So if you could help us understand, what is a medical examiner and where do they actually fit in to the whole sort of death and burial and bereavement process?
So not many people are actually aware of the medical examiner role. It is quite a new role. I think it started in September 2024. Prior to September 2024, when somebody passed away, the doctors looking after them issued a death certificate, and then that death certificate was then passed on to the registrar of deaths, and then a green form was issued, and then the family could carry out a burial or a cremation, whatever they wanted to do. Now, since 2024, the role of the medical examiner has been introduced. Now, a medical examiner is an independent doctor that wasn't involved in that patient's care, okay? And what we do is we scrutinise the care given to the patient. We scrutinise the death certificate just to make sure the death certificate accurately shows the cause of death.
Mm-hmm.
And another thing that we do is we make sure that the death doesn't need to be referred to the coroner. So there's a legal framework where certain deaths have to be referred to the coroner. So we need to ensure that they don't need to be referred to the coroner. And lastly, what we do is we sort of address any concerns that the family may have with the person's care or the person's cause of death.
Okay.
Really, okay?
So, if it's worked so well for so long, what prompted this change to have a medical examiner?
I think it's an extra step, given certain cases that have happened in the past, and I think one of the biggest one was Harold Shipman.
Yes.
Okay, so the notorious Dr. Harold Shipman. So what he was doing was he was giving medications to his patients who then pass away. Then he would do a death certificate by himself, and then that death certificate would then go to the registrar of deaths, and nowhere in between anybody would check the care given to the patients. Okay,
Right.
So one of the main reasons this was put into practice was just for an independent doctor to be able to scrutinise the care being given to the patient, and if the patient hasn't received the care that they should have been given, then we can sort of highlight that and take that back to the organisation to see things that can be done differently in the future, to try and improve the overall care of the patient as well.
So where would the coroner involved then? Where did they get involved?
Yeah, so the coroner is a separate service. So there's certain deaths that have to be referred to a coroner. Usually this is if a death has been caused by an unnatural cause, or the doctor isn't able to put down a cause of death. Then a referral is made to the coroner, and then the coroner will do their own investigations, looking at the cause of death.
Okay, and the whole thing around this is that to ascertain a cause of death.
Yeah, so make sure the cause of death is accurate, and also scrutinise the care given to the person that died.
So I suppose it may be that as a medical examiner, you're not just looking at the cause of death, you're also making sure that the care leading up, because there may have been some negligence. Right. Okay. Right. I want to talk now a little bit about what happens when someone dies. Okay. Can you do a walkthrough to help us understand? You get a phone call as a GP.
Yep.
Yeah. Your patient, Mr. So-and-so, has passed away at home. What do you do?
So for a death in the community, the doctor looking after the patient, so usually it's the GP, would go out and do a death certificate. Usually before you do the death certificate, any clinician, so any doctor, whether it's from the GP surgery, from the hospital, from the out-of-hours 111 service, and even sort of an advanced nurse can go out and verify the death.
Okay.
Death verification means that they go out and they confirm that the person has actually passed away. Okay. Once the death has been verified, then the doctor that was looking after that person, which is usually their GP in the community, would then do a death certificate for them, where they would write the cause of death. That death certificate is then passed on to the medical examiner's office, and the GP will also make a referral to the medical examiners just to inform them that the person has passed away.
Yeah.
Once that's been done, the medical examiner's office will contact the family just to let them know what's going on, and one of the medical examiners will review the death. Once the medical examiner is happy with everything, we sign off the death certificate, and then the death certificate is then forwarded on to the registrar of death, who will then contact the family to register the death.
So, if everything in that process that you've just shared with us, if there are no issues in that process, and it's a Wednesday,
Yep.
yeah, how long does that process take, for example? I'm not, it might be
Yeah.
a difficult question, but how long should it take?
So then, there's no average time, I would say.
Right.
Usually, if it's a straightforward death, within a couple of hours,
That can be done.
that can all be done. Yeah, within a
Okay.
few hours.
Because the reason I ask is because there are certain faith communities who need rapid burials.
Yep.
Yeah. So I'm talking about the Muslim community, the Jewish community, and I'm also looking at some other sort of communities who may not have a faith, but they may prefer, or it might be something within the advanced care plan that the person wanted a quick or rapid funeral.
Yep.
So, how rapid is a rapid funeral? How rapidly can it happen? In just sort of where there are no sort of issues.
I mean, in terms of the medical examiner office, as soon as we've received the death certificate, we can review that case as soon as possible, and we can so the healthcare setting and the medical examiner's office will prioritise cases that need a rapid burial.
Okay.
So for a medical examiner, sometimes it can take about 30 minutes to be able to review a case, sign it off, and then send it to the registrar's office. So it doesn't take a huge amount of time. The important thing here is when somebody in your family is in the terminal phase of their illness, you need to be having these conversations with the medical team looking after them, letting them know that when they do pass away, we would like to bury them as soon as possible. That will just help facilitate and help the medical team put things into place, so when somebody does pass away, they can do the death certificate as soon as possible and then get over to the medical examiner's office. Then we can prioritise that and review the case as soon as possible and then forward it on to the registrar's office. So I think having early conversations would really help in that scenario. So it goes
back to the advanced care planning.
Exactly.
Especially in cases where, there's a terminal illness, there's a terminal diagnosis, there's cancer, there's end of life or palliative care, where you have to have that communication with your medical team, healthcare team, so that, potentially, what are we going to do? Yeah. So that they're all aware of it, and once they're aware of it, it can be in their sort of medical file.
Yeah.
Yeah, whoever, so everybody's aware.
Exactly.
So communication again, and sometimes I think, Tariq, that these conversations are going to be difficult, because if that's your mum, dad, brother, sister, whoever, you don't want to go there, do you? You really don't. You don't want to be the one that's planning for this death.
Yeah.
But the reality is that, we do all die, or our life ends, or whatever, belief system that you have, our life's going to end at some point. Yeah, and we're no longer going to be here. And how do we sort of ensure that that's a seamless process? It's as easy as possible, yeah. And the only way to do that is have those early communications, with all the medical and the health and social care staff, so that they're aware of what's happening. Now we are coming to the end of the program very soon, so if you've just joined us, you are listening to Care Across Cultures with me, your host Mirwan Hussain. I've been talking and having a conversation with Dr. Tariq Sabir, who's a GP in Rotherham, I hope that we've touched on some topics which I know have real relevance within our communities: rapid burials, advanced care planning, fears, mistrust, GPs, and all of that kind of stuff. And as Dr. Tariq has said to you quite clearly, the health system is not set up to be cruel to you. It's here to actually help you. Now, it is a standardized process, but if you have an issue, the first point of call for any health related issue is go to your GP. And if there's a language problem or any other issue that you have which is a challenge, go to your GP and say, I need an appointment but I can't speak English, or I need someone who's I'm deaf and I need a sign language person. I don't really want my son with me at my appointment because I want to talk about something that's really personal and sensitive and I don't want them to know. So you have all of these opportunities, everything that you can go and do. So go and have a chat with them. Now, one of the things that, and I'm going to sort of focus this towards faith leaders, and I'm talking about death and dying. How can faith leaders help improve access to healthcare and hospice services within your sort of understanding?
So a lot of people that follow a faith usually will listen to faith leaders. Okay, so you'll find that they won't listen to what a doctor tells them, but when a faith leader does say something, they will listen to it and they will try and follow it. So I think it's very important for faith leaders to try and talk about these sensitive issues, talk about death and what happened after death, both in terms of a religious aspect, but also in terms of a practical aspect of what conversation you should be having with your family, and what the healthcare system can do to try and help people that are toward the terminal phase of their illness.
I know if you just focus on Muslims, for example, we hear about, at Friday prayers, that a lot about what's going to happen after death. Yeah. But one of the things that I've never heard, and it may be that I've just not been at the right masjid at the right time, and I'm sure some masjids are doing this, but what actually practical things that you can do. Because there seems to be a lot of differences of opinion, doesn't there? Some people, will grieve and mourn for 14 days, some will do it for 2 days, some for 4, some for 1, and it all seems to be very sort of different, doesn't it? And there's, but I think, whichever masjid that you are attached to, I think it's really important for the imams and the masjid committees to really sort of have a conversation about this at a khutbah. Because what do Muslims know? We are all going to die one day. We all know that.
Yep.
Yeah, and we know that we have to plan for it. Yeah, so maybe that's something that faith leaders can do as well. Okay. So we've talked a little bit. We're not going to go there because we've only got a few more minutes less. So what I want now is that if you could share one message with our audience today. It can be about cancer awareness, it can be about hospice care, it can be about GP access, it can be about anything that you want. What would that message be today?
So my take-home message for everybody will be, if you are invited to a cancer screening program, please partake in it, because a cancer caught early is a cancer that can be treated and cured.
I can't say any more than that. That's an amazing message. Thank you so much.
No problem.
For those of you listening and those of you who just joined us, you have been listening to Care Across Cultures on Link FM 96.7. I've been talking to the wonderful and amazing Dr. Tariq Sabir, a local GP in Rotherham, and I'm hoping that we're going to be doing some more collaborative work in the future in Rotherham and South Yorkshire. Thank you so much for listening. I'll be back next week with another programme. Allah Hafiz until next week.